When it comes to recovery from addictions, there's no such thing as one size fits all. Hear about a community-based approach that's likely to be a better fit for all of us next on Speak Your Mind. Welcome to Speak Your Mind. I'm Dr. Carolyn Phelps, licensed psychologist with the Human Development Center. This is the second of a three-part series that we're doing this season on addictions, and tonight we're going to focus on a multi-pronged community-based approach to recovery because addiction isn't just an individual problem, it's a family problem like we talked about last week, and a community problem. Tonight, I'm pleased to be joined by the Northland's leading expert in the treatment of addictions. I'll introduce him in a moment, but first, get ready to call in your questions about this topic. Locally, dial 218-788-2844 or call toll-free at 1-877-307-8762. We'll be answering your questions throughout tonight's show. Joining me now is Gary Olson, who's been the CEO of the Center for Alcohol and Drug Treatment since 1992. He's the recipient of the Lifetime Achievement and Leadership Award from the Minnesota Association of Resources for Recovery and Chemical Health. Thanks for joining us tonight, Gary.
Thank you, Carolyn.
And we talked about, in the introduction, I said a community-based approach, right. And you had mentioned that really addictions has a history of having sort of this one-pronged treatment approach, but we're going to talk about tonight about this sort of 5-parallel process that sort of encompasses more of the community into the concept of addressing addictions. Is that fair for me to say?
Yeah, it is. I mean, I think historically, there's always been some kind of response to addiction. This goes back to the beginning of our country. So, there's been different ways we've responded more traditionally through the criminal justice system or in some cases, the medical system. State hospitals played a big role. That's changed over the years, and I think one of my concerns is that we not expect too much from one domain in terms of dealing with the addiction as a community problem. Like you mentioned, it's an individual and a family problem, and on that level, that's a little bit different. But if we're talking about community problem, we have to recognize some of the collateral damage that's caused by addiction and realize that there isn't any single organization, agency, community domain that can effectively address the problems that go along with addiction.
And this is so much in the news these days because right. of what the news puts forth as a heroin epidemic or an opioid use epidemic. And is it really true that it's an epidemic, or is what we have with all of the news and the headlines an actual interest in and opportunity to kind of marshal resources where maybe there was less of, I don't know if I want to say less interest or less oomph or motivation behind that?
Well, I think the opioid epidemic is an example, though, of a trend that impacts communities in different ways. So, I had experience when I was working at UCLA back in the late 60s, working with heroin addicts and methadone and so forth, because in the big cities, that's always been a problem, and a lot of the strategies have been developed. But as these things have impacted smaller communities like our own, without the resources to really cope with it, the impact seems proportionately greater, even though overall it might not be that big of a change. It's a shift in where the communities that are affected. So in our area, we're kind of at ground zero in Minnesota for opioids, and this is kind of a complicated reason why that might be so. But I think some communities, smaller communities, have less resources to cope with these collateral impacts. I've always said, for example, that heroin brings big city problems to small towns. So law enforcement is challenged in a way now that they weren't maybe 20 years ago. So, so it's that disparate impact too that I think requires communities to really mobilize their resources in a very intelligent and strategic way in order to cope with the problem.
Talk a little bit about the collateral damage that you've now referred to a couple of times.
Well, I mean, you know, addiction always has those aspects. I mean, even when we say addiction, it's a general term, so we all, I think, understand what we're talking about. But there are significant differences between, how some drugs are managed and what the impact is. I mean, in the case of alcohol, of course, it got so bad in this country, we passed a constitutional amendment trying to manage that addiction, and it's always been a big problem up here. But there's behavior associated with addiction that people are responsible for, and I think one of the things that we have to recognize is we are all responsible to behave legally in our own lives, and people that struggle with addiction are no different. So there's some of that is the illegal activity around obtaining drugs or alcohol or things like impaired driving. These have huge impacts on our community, and of course mortality, which is the thing that we're most concerned about right now with the opioid epidemic. But I want to remind people that alcohol kills about 88,000 Americans a year, so it's about twice what the illegal drug overdose problem is. So those are the kinds of things that happen. It impacts, schools. It impacts hospitals and emergency rooms. It impacts law enforcement, social services, child protection. All of those kinds of things are secondary to what we know is the real problem, which is the addiction.
I like what you said too about reminding us about how many people die just from alcohol addiction, because I think there's this tendency to focus on the drug of the times, whether it
Right.
was methamphetamine or cocaine back in the 80s and maybe now heroin right now,
Right.
as if all of a sudden all of the other problems just disappear and people aren't having problems with these other drugs, including ones like alcohol, which is legal in all 50 states.
Well, we talked about the meth epidemic a few years ago when that and the way I've been thinking about it is if everything you know about addiction is based on what you read in the news or see on the news, it's a very distorted picture of what's really going on, because news tends to focus on things in that way. They're selling newspapers, or they're selling things, so it can kind of distort that. But there is there is a level at which this problem has been with us for a long time, and there are differences. So meth epidemic is an example that really hasn't gone away at all.
Right.
It's just that it's not having the notable impact that the opioid problem is right now.
So within these 5 parallel strategies, the first strategy we're going to talk about is prevention. Then, and talk about how you see that as important in the community and what that ought to look like when it's being done well.
Well, of course, we could do 3 programs on prevention alone. I mean, there's, it's a public...
He just made a promise to come back on the show. You heard that, right?
It's a public health approach, and, they talk about primary prevention, which is if we can prevent something from occurring at all, that's primary prevention. So vaccinations is an example of primary prevention, and secondary prevention and tertiary prevention. So there are stages of prevention, but I think in the case of the current situation, prevention, it would include things like public education, so people understand that the drugs that are prescribed by their physician are as dangerous as the drugs that come off the street. But people need to understand that. They need to understand the risks associated with certain drugs. So getting accurate information out to the community is a prevention strategy.
And here's a question, I'm going to interrupt you a second,
Okay.
that kind of ties into what you just said, which is why are some, and this is a gentleman calling in from Duluth who is asking, why are pharmacists being held more responsible for sort of medication-related drug problems? And so number 1, is that an accurate statement? And then number 2, what's your thought about that?
Well, I haven't heard so much about pharmacists being held accountable, but physicians certainly are.
Right.
And so I've spent a lot of time the last 2 years talking with physicians, working with the health systems like Essentia, because frankly, to talk about prevention, one of my biggest concerns right now is we have tens of thousands of people on long-term opioids through their physicians, some of whom are experiencing problems with addiction. And we need to try to keep those folks there and get that treatment to them where they're at, instead of waiting for them to be cut off by their physician and end up drug seeking on the street, which it puts them at much greater risk and ends up, you know, a much bigger problem for everybody. So that's a kind of a prevention strategy. It's not a primary prevention, but if people are experiencing addiction on those prescribed opioids primarily, we want to try to get the help to that patient while they're still engaged with their physician. So.
And that secondary prevention in actually, you know, in the work that I do with the people, treating people with eating disorders, the research indicates that actually prevention interventions that are targeted at those who are most at risk tend to be the most successful.
That's
in
right.
terms of decreasing further damage down the road.
Right. So if I could tell you how we could prevent addiction from occurring in the first place, I would.
Right, you're not holding out on the community
no, I'm not holding
of
out on
Duluth.
that. At this point, we don't really even know who's vulnerable to addiction. We know that a certain percentage of the population is vulnerable. It's about exposure. So if you expose 100 people to a particular drug or activity, even a certain number, it's going to trigger that addiction. So we don't know ahead of time. I suspect within 5 to 10 years we may have some genetic evidence that can help us target high-risk individuals. But right now, you know, we have to look at the correlation with things like adverse childhood experiences. Childhood trauma is highly correlated with addiction. So if we can prevent that, we might be able to prevent addiction. But there's no direct kind of line. We don't have a vaccine or an intervention that can target the right people to prevent addiction.
Yeah, no magic 8 ball
no,
here.
No, there really isn't.
The second of the parallel strategies, treatment, which is something that we're more familiar with then.
Right, and you know, part of my interest, since I represented a treatment agency, is to help people understand the limitations of treatment. You know, what it can and can't do, and also address some of the problems of accessing treatment, because what's so frustrating to people, particularly families now who have a loved one that's struggling with an addiction, is they can't get help for them when they're ready for that help. So there are a lot of issues around that. So we need to, the strategy then is to make sure that there's a range of treatment, because not every treatment works for every person. Treatment is not the same thing in treatment center A, B, and C. There are some differences in how we do treatment and what our treatment philosophies are. So we want to make sure that we have access to treatment when people ask for it. I mean, it's one thing to try to get people in treatment who are resistant to treatment, but we have people who are begging for treatment that can't get into treatment, and that's really unacceptable. So I think, you know, we need as a community to be sure that we're doing everything we can to connect people with the appropriate treatment, and that's what we're working with in the ORS group, the Opioid Abuse Strategies, Response Strategies work group, with representatives from around the community, is to try to work to solve some of these problems. But treatment is a very important component, right?
And then recovery support? Recovery
support. So in my experience, a lot of treatment has been, you know, a 28-day stay in a rehab program, a graduation ceremony with a medallion that says, good luck, go out, go to meetings and have a good life, but that's kind of the end of the line. And we know now, and I think it's not a surprise, that treatment is a process. Or a recovery is a process. It's not, it doesn't end. The treatment is really the very beginning of the process. The recovery process is a long-term proposition.
And I think that that's even more true if you're talking about treatment programs that you go away to or that you live in where you are also, like, you're absent of your life
Right.
in those programs, and they might be necessary for some people at some stages, but that whole reentry into the real life universe suggests that you better have something else going on.
But you know, Carolyn, we don't even have callbacks to outpatient treatment, for example. So what happens is people who've made a commitment to abstinence, for example, or sobriety, if they fail to achieve that or have a lapse or a slip, their sense of embarrassment and shame and feeling of failure prevents them from coming back quickly enough to kind of get them back on the road. So recovery support is really a community-wide thing, and it includes things like making sure that people that are in recovery from addiction have opportunities like job opportunities and housing and some of those kind of things that are supporting long-term recovery. So that is an effort that I've been working on with a foundation called the Victory Fund here in Duluth that focused on chronic disease, and we're developing an RFP, a request for proposal, to send out to help develop more effective recovery support services in the community that aren't connected to a treatment program, that are independent from that, and deal with multiple pathways to recovery, because people don't just recover in one way.
I think that a lot of people think of recovery support as being something like 12-step meetings, which
Right.
they're so, or Celebrate Recovery meetings, which they're so familiar with. But you named other types of recovery support, such as employment and housing, which we know that if people don't have access to those, they act to really increase your risk for relapse, and simultaneously the positive effect that they can have on continuing, helping somebody to continue on the path of recovery.
Well, I mean, if we think about making any other change in our lives, changing our diet, changing our exercise, commitment to exercise, there are a lot of issues with actually implementing that plan over the long run, right? or continuing to stay engaged with that recovery
People
plan.
are good at starting. It's the
We're
continuing.
very good at starting. Actually, we're even better at preparing to start. So we're going to start tomorrow, right? That's
Right.
kind of where we get stuck. But in this process of recovery, we have to consider not just the abstinence or the sobriety part of recovery, because that's very important, obviously, for people, but the context of that. So what other stressors are in their life? What other obstacles do they have? Because recovery is also about improving health and wellness, just generally, and living a self-directed life, so being able to take more responsibility for your own life, and striving to achieve your potential as a person. So it's really everything that falls along that slope would be recovery support.
Which is all about sort of creating a life worth living.
Right, that's right. A sense of purpose and meaning in life is probably the most important thing for anybody, especially in recovery. And to some extent, the 12-step programs really offer that. And I want to put in here that not everyone needs to go to treatment to recover. The beauty of the self-help programs like Alcoholics Anonymous and Narcotics Anonymous is all you have to do is show up, and there's no cost, there's no regulatory environment. It's there for you when you're ready for it. But comparing that and treatment is like not apples and oranges, but kind of apples and footballs. I mean, they're really very different, because we're looking in treatment, professional treatment, at all those kinds of other things around addiction, including maybe some underlying issues.
Harm reduction, the fourth prong.
Harm reduction, we have in our community now, we have a syringe exchange, a classic harm reduction strategy. People have already made the decision they're going to inject drugs, but if they share needles, there's a risk of spreading bloodborne pathogens, infectious diseases, particularly hepatitis C. And we've seen a spike in hepatitis C in our community, and then also an increase in HIV infections. And we don't want those two things to merge into that same population. So harm reduction is about reducing the risks and harms, not just for the individual, but for the community as a whole, because we all benefit from, keeping intoxicated people out of cars. So if we can figure out a strategy like the bus rides home on New Year's Eve is an example of harm reduction.
That's wonderful, because I think a lot of people hear this phrase harm reduction, and what they think in their head is, you mean you're going to give a junkie needles, so you're supporting the habit, and they don't see how, it actually is reducing these other problems and is increasing your safety and the community's safety as well.
Exactly, and that's medication-assisted treatment is a good example, because what we're doing is moving people from unsupervised, unregulated, out of control street drug use to a medically supervised, stable, regulated medication replacement until they stabilize enough to make some of the other changes and move into recovery. So that's also a harm reduction strategy.
And then the fifth prong is enforcement and regulation. And talk about that, because when I hear that, I think law enforcement or legalization of certain drugs. And
yeah, I mean, I think regulation is important in a number of ways. So for example, long-term strategy with opioids is to reduce the kind of prescribing practices that have been in place for many years. So regulating how those drugs are prescribed, under what conditions, those are kind of the issues that we're looking at when we talk about regulation enforcement. So it's not just law enforcement; it's the pharmacy regulations, it's the disposal of drugs. There's a whole range of activities.
So even that whole thing of now, in order to buy Sudafed, the Sudafed is kept behind the counter in the pharmacy.
That's exactly right.
In response to the whole making of meth and Breaking Bad.
Right, and we could argue that a lot of these things are overlapping, so that kind of sounds like a prevention strategy, but they're not like in these neat little buckets. There is significant overlap between those strategies, but what I've suggested and what we're working on at the ORS group is that we really need to be doing all of these things simultaneously, not put all of our eggs in one basket, but really try to move forward as a community in a collaborative way to make these different efforts work together.
What do you see as because we're getting near towards the end of our time now, what do you see, because you've been working with the community as a whole, not just with individuals in the community, not just, although, you're the CEO of the Center for Alcohol and Drug Treatment, you do so much more than just the treatment.
That's right.
And so what do you see as the hope for our community in the future direction of this?
Well, I've been working now in Duluth for 46 years or whatever it is, pretty much the entire time around the issues around addiction and housing issues, homelessness. And the level of collaboration and cooperation in our community is really exceptional. So I think building on that, it's a very natural thing to build on, and we really are exceptional in that way. And because we're isolated geographically, the things that we do, the things that we try, we can measure the impact of those a lot easier here than you might be able to in a big city. So we have some strategic advantages, I would say, as a community in dealing with these kinds of problems.
So one is the geographic location, and the other is the willingness of the human beings in our community to come together and collaborate for the greater good then.
It's really, when people come from the outside, it's one of the first things that they notice is the level of cooperation and collaboration amongst providers. There's not the kind of competitive kind of dog-eat-dog mentality that you see in some places, and so that's a great advantage.
That's a wonderful message of hope, I think, for us to end on tonight, that we are this wonderful community that knows how to come together, and you are a part of that community too. And so I think we all share some responsibility in doing what we can, in collaborating how we can, whether that means helping your neighbor with a particular problem, or today we're talking about addictions and where you fit in on that, because we all fit into that equation someplace. Thanks so much for joining the discussion with us tonight, and don't forget to visit us on the web at speakyourmindonline.org, where you can find a schedule of our topics and resource links. Join us next week for part 3 in our 3-part series on addictions, when we'll be talking about how to kick the tobacco habit even when you believe you can't, and you believe you can't because you have failed and failed and failed. And if you want a little inspiration, you ought to turn on the TV set to ESPN and watch some of those reclips of the Cubs, because they know something about perseverance through failure. I am Dr. Carolyn Phelps. Thanks for watching, and good night.